Good afternoon, everyone. My name is Roshan Prashant. I'm a Bachelor of Philosophy honors student, and this is the title of my honors thesis. It is Machine Learning of Changes in Radiomics Features Extracted from FET PET Images after Radiotherapy in Patients who were diagnosed with glioblastoma. My supervisor is Dr. Martin Ebert. And today I'll be going through the background of the current state of research in FET PET radiomics, as well as the aims and method of the study, the research that I've conducted in the last year, as well as the main findings, limitations, and the implications this has on this field. Glioblastoma is a grade 4 tumor of the central nervous system. It accounts for 54% of all gliomas and 16% of all brain tumors. The 5-year survival rate of patients who are diagnosed with GBM is less than 5%, despite improvements that have occurred with a combination of radiochemotherapy. The median survival continues to be approximately 15 months for patients diagnosed with GBM. There are two primary types of GBM. There's primary glioblastoma and secondary glioblastoma. This is illustrated in this figure here. So primary glioblastoma usually arises spontaneously and is known as IDH wild type. And this is because only 3.7% of primary glioblastomas have a mutation in the IDH gene. Secondary glioblastomas usually arise from a lower grade astrocytoma, which is another type of glioma. And most secondary glioblastomas also have a mutation in the IDH gene, as shown here in the flowchart. The current gold standard in diagnosis of GBM is structural MRIs, as this guides radiotherapy and surgical excision. The MRIs involves intravenous administration of gadolinium, which then circumscribes the tumor, resulting in what's known as ring enhancement. GBM in particular exhibits irregular ring enhancement, and this is shown in this image here, where there is a very irregular border around this tumor region. This is indicative of the disruption in the blood-brain barrier. Alternative MRI methods such as MR spectroscopy and functional MRI have also been used to try and complement the structural MRI methods. The current protocol regarding treatment for glioblastoma involves maximal surgical excision followed by radiotherapy, with the dosage is usually around 60 grays, and this is delivered in 30 fractions, and concurrent use of temozolomide, which is a chemotherapeutic agent. Targeted therapies have also been used to try and treat glioblastoma, such as monoclonal antibodies, since these inhibit tumor angiogenic pathways, and these have had some success as well. However, despite all of this, there is still an 80% recurrence amongst patients who are diagnosed with glioblastoma and undergo surgical excision, especially amongst those for whom the tumor has been delineated using MRI methodologies. So a frontier in research for GBM diagnosis is the implementation of PET imaging. And this involves the injection of a radioactive tracer, which emits positrons, which annihilate with electrons in the tissue. So as seen in this, as illustrated by this diagram here, the annihilation between the electron and the positron produces two photons that travel in symmetrically opposing directions, which then interact with scintillation crystals in the detector that surround the individual, and this produces an electrical signal. This phenomenon is known as the annihilation coincidence detection, and is how PET images are produced. The specific tracer relevant to this project is 18F fluoroethyl tyrosine PET, fluoroethylene tyrosine, also known as 18F FET or just FET. This comprises of a tyrosine analog in its tracer and is paired with fluoride 18, which has a half-life of around 110 minutes. The transport of FET across the blood-brain barrier to the tumor regions is facilitated by the LAT1 and 2 transporters that are found on the cellular membranes on the blood-brain barrier, and the concentration of LAT transporters are increased in the case of gliomas, thus highlighting that this tracer thus highlighting the utility of this tracer amongst patients who are diagnosed with glioblastoma. FET PET images and their analysis usually revolve around accumulating static and dynamic features over a course of approximately 20 to 40 minutes post the injection of the tracer. The primary static features that are analyzed are SUV, standardized uptake value, and TBR, tumor to brain ratio. The tumor to brain ratios are determined by comparing the level of tracer accumulation within a tumor region with a crescent-shaped region of normal brain tissue encompassing both gray and white matter in the contralateral hemisphere to which the tumor is in. SUVs are obtained from TBR values and are as mentioned in the name, they are standardized according to body weight, and this is to facilitate comparisons between groups of patients as well. The dynamic features from FET PET scans are usually in the form of time activity curves, and an element of time activity curves that has shown prognostic power is the time to peak. So a couple of examples of time activity curves are demonstrated here, where the y-axis is the SUV and time is shown on the x-axis. The time to peak refers to the time at which the SUV value reaches its maximum. So in this graph, it's here, and in this graph, it is here. The current literature has found that an elevated TBR and an earlier TTP is associated with a higher grade glioma, and it's also associated with tumor progression as well as poor prognosis. This is evident in this figure here, where there is an early TTP at this point here, and this correlates with a grade 4 astrocytoma, which would be classified as a glioblastoma. On the other hand, a decreased SUV and a later TTP, especially post-radiotherapy, has been associated with longer progression-free survival. So that's evident in this figure here, where the TTP occurs quite late, and this corresponds to a grade 2 astrocytoma. It has also been found that the optimal diagnostic performance of FET PET scans has occurred when the TBR threshold to distinguish tumor regions from normal cerebral tissue is set in between 1.6 to 2.1, and this is in the context of glioma delineation. Another frontier in the research for FET PET, in the research of FET PET analysis is the inclusion of radiomics analyses, and this involves the determination of quantitative features of a static image from the tracer uptake within each voxel. A voxel is the three-dimensional analog of a pixel. The radiomics features analyzed in this study are known as manually defined features, which are split into semantic and non-semantic features. Semantic features are qualitative features that are defined by radiologists, and they have a clinical utility. On the other hand, non-semantic features are quantitatively determined and mathematically defined. Non-semantic features also separate into first-order features and second-order or higher order or textual features. Those are all synonymous with one another. The first-order features indicate the distribution of tracer accumulation intensity within any given region of interest, and this is usually the tumor volume of interest in the case of FET PET scans. Whereas second-order or higher order or textual features provide an insight into the statistical relationship that is present between groups of voxels, and this provides an insight into tumor heterogeneity or homogeneity. An example of the derivation of a textual feature is shown in this figure, where groups of voxels are being compared with one another, and a mathematical relationship is used to determine a radiomics feature, in this case, intensity variability. And in the context of FET PET analysis, this is analogous to gray level non-uniformity of zone. The current literature also explores the potential utility of radiomics analyses for glioblastoma grading from FET PET scans. For instance, a study done by Carles et al. Using the MathWorks software found that the feature SZLGE was positively correlated with earlier tumor progression and poor overall survival. Furthermore, additional studies have also been done to analyze the repeatability of FET PET features, since this provides an insight into their validity and reliability if they were to be implemented in clinical practice. One such study was done by Guche et al. Using the PyRadiomics software, which was also implemented in this study. And the PyRadiomics software is based on the IBSI guidelines. And this study found that the first-order radiomics features, GLS-ZM and GLR-LM features exhibited a high repeatability. Another study by Barry et al., this is actually Nathaniel's paper from last year, also implemented a similar methodology using PyRadiomics as well. And the finding from this study was that the shape first-order features and GLCM features exhibited high repeatability. This paper also conducted an analysis of prognostic modeling by implementing a suite of machine learning algorithms to find the features with the greatest predictive power. Examples of the feature of the machine learning algorithms implemented were a random forest classifier, linear support vector machine, extreme gradient boost, and linear discriminant analysis. The best performing model in this study comprised of at least one textual and one first order feature. And these features were selected using a linear SVM based recursive feature elimination algorithm, which I will circle back to in a little while. To provide a bit of context, machine learning in general is a branch of artificial intelligence, whereby an assortment of algorithms learn the correlations between a set of predictors, which act as dependent variables, and outcomes, which act as independent variables. In this study specifically, supervised machine learning algorithms are used. So in these, the predictors and outcomes are already labeled, and there is a defined train to test split of the data. So usually with machine learning, the whole data set is split such that the machine learning model is trained on some proportion of the data set, and then the model, upon learning on that training data set, is then making predictions on the remaining data that was not used for that training, and that's known as the test data set. This study investigated the FET PET scans from 24 patients who were diagnosed with histologically confirmed GBM and treated with radiotherapy or radiochemotherapy at Sir Charles Gardner Hospital. It's important to note that this study did not consider low-grade gliomas. It was all of the patients had grade 4 glioblastomas. The main aims of this study were separated into different stages. The first of which was to construct machine learning models that could predict the overall survival from changes in the static FET PET radiomics features. The next stage involved the inclusion of dynamic FET PET image features in the form of TTP, which was added to the best performing model from part A. And then subsequently in part C, the demographic attributes of the patients, as well as the clinical information that was made available, was added to the best performing model from part B. Furthermore, an analysis of the existing literature has shown that the correlation between changes in FET PET radiomics features after cancer treatment has not yet been extensively explored. And so another aim, the purpose of the study is to lay out a methodology to determine the changes that are most strongly correlated with successful treatment. All 24 patients underwent PET and CT imaging approximately 4 weeks prior to radiotherapy or radiochemotherapy, and 20 of these patients also underwent a final scan post-radiotherapy, and this was either 1 to 2 weeks or 6 to 8 weeks, depending on the particular patient. During the PET scan, approximately around 200 megabecquerels within 10% of FET tracer was injected, and the dynamic FET PET scan was conducted over a period of 18 minutes, with the TBR threshold to define tumor regions set at 1.6. Furthermore, B-spline interpolation was used to render isotropic pixel spacing, and this is a method, in essence, to draw smooth lines between to connect a series of points. And then also the accompanying CT scan that was conducted with the PET scan was used to convert DICOM files to a binary mask to facilitate radiomics analyses. A structural MRI was also conducted for each patient, and this was then used by physicians to remove regions that were clearly that were identified by the FET PET as tumor regions that clearly were not neoplastic. The PyRadiomics version 3.0.1 was used in this study, and using this 100 static FET PET radiomics features were extracted from all of the images, and the voxels were grouped in bins with a width of 0.1 on the basis of tracer accumulation. The dynamic features were obtained using the MIM software, whereby the static FET PET image was overlaid over the dynamic scan, and then a spherical 2 milliliter contour was drawn around the point of maximum TBR within this tumor volume of interest, and the SUV max within this 2 milliliter contour was traced over a period of 19 minutes approximately, and this produced a time activity curve. The resolution of this time activity curve was 30 seconds. So that is, during the dynamic scan, the levels of tracer accumulation were taken in intervals of 30 seconds. Then finally, the absolute and relative change in static and dynamic features was determined and then standardized, and the overall survival of the patients was changed into a categorical variable by setting poor survival to be 0 and good survival to be 1. where the threshold between poor and good survival was 450 days, which is approximately 15 months, which is the median survival for GBM. In the machine learning segment of the study, leave one out cross-validation was implemented to assess model performance. And the different machine learning algorithms implemented in this cross-validation was random forest, logistic regression, and gradient boosting. So this figure here shows how leave one out cross-validation, how the leave one out cross-validation algorithm works. So if we have n samples, n minus 1 samples are set aside for training the machine learning model, and the final data point is used for the test in one iteration, and the trained model makes a prediction on this test data point. This process is then repeated, where now the next data point is used as the test, and the remaining n minus 1 are now used as training. And this process is iterated through until we have n distinct predictions made by this cross-validation, which can then be used to assess model performance. This methodology of cross-validation aims to utilize the diversity of this small data set of 20 patients as splitting this into in the form of a classical train test split would not yield sufficient statistical power. In part A, the 4 strongest predictors were selected for this cross-validation process, and this was done using recursive feature elimination. In recursive feature elimination, the machine learning model is essentially distilled till the number of where a machine learning model is distilled until the number of predictors is reduced till the desired number. And this is done in an iterative process where the predictors with the least predictive power or prognostic power are removed one by one. So the recursive feature elimination method used the machine learning algorithms of random forest, linear SVM, and gradient boost to select these features. In part B, the absolute and relative change in TTP was then added to the best performing model from part A and then compared to the models in part A. And then in part C, the demographic and clinical data was also added to the best performing model from part B, which had the best performing combination of static and TTP changes. We do note that in part C, the sample size of the patients was reduced from 20 to 19, and this was because the methylation data was unavailable for one patient. Furthermore, a brief redundancy test was conducted in the form of multicollinearity assessment amongst the static features, as well as between static and dynamic features. And this was a test for redundancy in the machine learning models. Now, all of the models in parts A, B, and C were compared to a control group. And the predictors used for the control group were the sex of the patient, age, and methylation status. The IDH status and cell type of the cancers had to be excluded due to insufficient heterogeneity in the data. So the best performing model that was obtained from the control data set was a cross-validation that implemented a random forest classifier. All of the models were assessed on the basis of accuracy, sensitivity, PPV, F1 score, as well as the areas of the PPV versus sensitivity curve, which is also known as a precision recall curve. They're both equivalent. And the area of the sensitivity versus 1 minus specificity, also known as ROC curve. All of these parameters vary from 0 to 1, where 1 implies that it is able to perfectly discriminate between poor and good survival, and 0 indicates that it is completely unable to do this. The accuracy of 0.526 and the area under the ROC curve of 0.5 in this best performing model for the control group indicates that it was unable to distinguish between poor and good survival. And furthermore, the value of the PPV, which was 0.5, and the area under curve of the precision recall curve, which was also approximately 0.5, shows that this model also had poor performance at identifying true positives, which is what essentially sensitivity is. The absolute change in the best performing model in part A was the absolute change in static features, and the strongest predictors were identified using a linear SVM algorithm within the recursive feature elimination. And then the best model performance was obtained by conducting a logistic regression in the leave-one-out cross-validation. The accuracy of this model was 0.9, and the sensitivity was 1, and the area under curve for under both of these curves was approximately 1 as well. And so what this indicates is that this model was highly effective at predicting overall survival of patients. Furthermore, the 4 strongest predictors that were picked out by the RFE algorithm were quantitatively analyzed using Pearson correlation coefficients. And it was found that the 2 GLCM features of different average and sum squares had a moderate negative correlation, whereas the GLS-ZM and shape surface area features had a negligible positive correlation. Previous studies have shown that GLCM and GLS-ZM exhibit high repeatability. And so this knowledge, along with the results from this study, whereby the GLCM features have a moderate correlation with overall survival, could represent aspects of the tumor, of GBM tumors that could be correlated with the overall survival of patients. Furthermore, a comparison between Model A and the control group shows that Model A systematically outperformed the control group model on all of these parameters. In part B, the best performing model was when relative TTP, the change in that was added to Model A, and when a random forest-based cross-validation was conducted on it. Similarly to Model A, the accuracy was 0.9, and the area under curve for both of these was also close to 1. And so this also indicates that this model was highly effective at accurately predicting overall survival. A comparison with the control again shows that it outperformed the control models on all of these parameters. However, a comparison with Model A shows that despite them both having a very similar accuracy, Model A outperformed Model B on all of these parameters. So Model B had a slightly poorer performance. An analysis of the correlation between TTP and overall survival also showed that there was a low negative correlation between change in TTP and overall survival. So this is actually contrary to the existing literature, which suggested that a later TTP was indicative of better patient outcomes. This could be attributed to the small sample size of this study, whereby the contribution of errors would have an exacerbated impact due to only 20 patients being surveyed in the machine learning model. Another reason could also be attributed to the fact that in this study, only glioblastoma was studied, as opposed to gliomas, which is usually what the existing literature looks at as a whole. So there may also be an underlying physiological difference between the tumors. In Model C, which included absolute change in static features, relative change in TTP features, demographics, as well as clinical features, the best performing model was a logistic regression-based Leuvenhoek cross-validation. And this yielded, once again, an accuracy that was very similar to that of models B and A, and a very high sensitivity. And once again, the areas under the curve were very close to 1. So this shows that this model was also effective at accurately predicting the overall survival. A comparison with the other sets of models showed, once again, that this vastly outperformed the control group. And a comparison with Model B and A showed that, as with Model A, Model C performs better than Model B, and the parameters are quite similar to that of Model A. A larger patient sample size and repeated tests would be required in order to distinguish between models A and C. Furthermore, a comparison with the existing literature on this topic, which there is not much of, but a comparison with whatever was made available showed that in the case of, for example, with Barry et al.'s paper, that the best performing machine learning model in this paper had a very similar performance to that of models A, B, and C in this study here. So very similar sensitivity and accuracy as well. And in fact, the area under curve for all 3 models in this study were higher than the 0.879 found in this paper. And so what the findings between both of these papers do corroborate with one another, and thus indicates that FET PET could have an application in treatment evaluation as well. There were several points of limitations and areas that could have been improved in this study. three of which I shall be discussing now. So one of the main ones was sample size, as there were only 20 patients surveyed, 20 patient sets of patient data analyzed in parts A and B, and only 19 in part C. So larger sample sizes are necessary in order to separate the data set into the classical train and test models that are required for machine learning. And despite the implementation of the Leave-Monod cross-validation, these models likely do not have sufficient power, statistical power, and so multiple independent studies are necessary on larger patient cohorts to either validate or to challenge the findings of the study. Furthermore, the resolution of the dynamic data could have also played a role in the contrary findings of this study in comparison to the existing literature regarding the relationship between TTP and overall survival. The 30-second resolution created erratic and multiple local maxima, so that made it quite challenging to identify the specific point at which the TTP occurred. And furthermore, differences in TTP of less than 30 seconds were undetected, and so this indicates that a higher resolution was required to identify these. Perhaps also treating TTP as a categorical variable could have assisted in this process, as other studies have set a threshold TTP that separates between early and where TTP has just been separated as an early or late variable. So once again, like a binary classifier, 0 and 1. And those studies have demonstrated that later TTP is associated with better patient outcomes. Furthermore, an analysis of the multicollinearity amongst the static and relative TTP was also done. And it was identified that the feature original shape surface area had a low correlation with time to peak. So this indicates that some redundancy may have been present, particularly in models B and C. And furthermore, an analysis amongst just the static features is shown in this heat map here, where blue indicates a high level of correlation and yellow indicates a very low level of correlation. And so in this map, there are these clusters within these regions of blue regions, and these correspond to shape features and first order radiomics features. So this indicates that shape and first order features may be correlated amongst one another or with one another. And so this could further add to redundancy in the machine learning models investigated. And so in this study, 3 sets of machine learning models were produced to predict the overall survival from the change in static and dynamic features after radiotherapy was conducted amongst patients with histologically confirmed glioblastoma. The main findings of these models was that all three model A, B, and C vastly outperformed the control group, which only consisted of demographic and clinical features, and that models A and C outperformed model B, which had static and dynamic features only. The strongest static feature predictors of overall survival were found to be these 4, and in particular, the GLCM difference average and sum squares were found to have a moderate correlation with overall survival. The relative change in TTP and its correlation with overall survival was the inverse of what is found in the literature, and so these findings indicate that further studies on larger sample sizes are required, and this is on top of the limitations that were just previously discussed. Future research into the following topics could certainly provide an interesting perspective on FET PET research. One of them being the translation of radiomics features across various different softwares. So there was actually a meta-analysis where they used a similar software to Carles et al. That identified the feature SZLGE subscript GLSZM, which indicates that there may be an overlap between the softwares MathWorks and PyRadiomics. However, further studies are required to help identify the specific relations and to facilitate more in-depth comparisons between FET PET studies implementing different softwares. Furthermore, the integration of radiotherapy characteristics, as well as histological findings and MRI along with FET PET could enhance the prognostic power, as indicated by the improvement from model B to C as soon as demographics and clinical features were added to the models. And also, finally, deep learning and also hyperparameter tuning could be implemented in future research, especially on larger data sets. So deep learning is better suited to larger samples than machine learning. And so larger samples of patients could facilitate the application of deep learning and provide a new insight into the relationship with overall survival. And furthermore, something known as hyperparameter tuning, whereby the machine learning algorithm parameters are adjusted to optimize model performance, could also be implemented to further enhance the performance of these machine learning models. In the future, implementation of the deep learning or hyperparameter tuning on large sample sizes that integrate radiotherapy, histopathological findings, and MRIs could perhaps provide models that are able to recommend or prescribe a radiotherapy treatment for a given patient with a specific glioblastoma tumor. But regardless of this, it's quite clear that FET PET continues to play a pivotal role in the diagnosis, treatment planning, and treatment evaluation of glioblastoma. Thank you very much for listening, and here are the references from which I obtained the information.
Okay, thanks very much, Roshan. Brilliant. Before I ask for the questions, I need to forward to introduce Roshan. Roshan is doing honors in theoretical physics, just in case reviewers just want to mark Roshan's presentations and in the future, next stage, the thesis. You need to evaluate this project based on 4 research units, not 6 research units, which is for masters. But this research has been done by Roshan, is just 4 research units. Well done, Roshan, and all the best. So now open to questions. Yes. Who is first? Need to check. Yes, Jake, please.
Yeah. Hey, Roshan. Really good presentation. I particularly liked that you compared the results of your model with a model comprised entirely of clinical variables. This is actually becoming a reporting criteria for a lot of sort of AI machine learning model recommendations. So I think you're a bit ahead of the curve when it comes to certainly a lot of literature that's out there at the moment. I have a couple of questions. The first one is that with respect to that model that you built on the clinical variables, I noticed that it only included 3 clinical variables. I think it was sex, age, and something else.
Yes, this one.
Do you think there's any other clinical variables that you could include that would potentially improve that model, or any other clinical variables that are used by sort of physicians when looking at glioblastomas?
Yes. So when we had a look at the control group, the aim was to actually just look at demographic and clinical features. And within the data that was made available, there was information regarding the IDH status as well as the cell type of the tumor. However, because the sample size was quite small of patients, in the case of IDH status or cell type, it was found that there were maybe 4 or 5 different categories for each of these variables, but of the 20, there were around 17 that had one, and that had the same one, and and some of those categories weren't represented at all. And so when we compare that to the existing epidemiology of the distribution of the different kinds of glioblastoma, they don't quite match, and so it doesn't really it's not really a stratified sample, which could introduce some bias.
Correct. Yeah. Okay. I understand.
But yes, of course.
Do you know
in the future it could be?
Yeah. Do you know if by any chance those particular clinical variables are prognostic for patients with glioblastoma? So would you expect them to actually contribute to the model if they were included?
So from my understanding and from reading the literature, IDH status is indeed correlated with the outcome of patients who are diagnosed with glioblastoma. In particular, wild type individuals diagnosed with IDH wild type glioblastoma tend to have a shortened survival. It tends to be about half of those diagnosed with IDH mutant glioblastoma. And usually with the cell type, a large proportion of glioblastoma, from my understanding, is either spontaneous or arises from an astrocytoma. And so there wasn't as much literature as I guess I thought when when analyzing different kinds of glioblastoma origins, such as oligodendroglioma origin glioblastomas, there wasn't as much literature regarding that. So I'm not too sure regarding that segment, but with IDH status,
Okay.
yes.
Yeah, so there's a possibility that with a larger sample size, with these clinical variables included, that it could, this particular control group model could become more predictive.
Yes.
But you did the best that you could with the sample size that you had. So can I ask another question as well, Pejman, or should we pass someone
absolutely.
else? Okay. Just with respect to the treatments that the patients had, I think you mentioned that they underwent radiochemotherapy. Was that standardized for all of the patients, or did some patients undergo different kinds of treatment? And if so, do you think that would have affected the results of your model?
The patient FET PET data was actually obtained from a previous study that had been conducted from 2014 to 2018 on different forms of glioblastoma treatment. And from my understanding, the radiotherapy and the radiochemotherapy was standardized, but I'm also and yes, of course, if there were differences in the radiotherapy, that certainly would have also added a confounding variable. But on top of the standardization of the radiochemotherapy, there may also have been other clinical interventions, such as surgery, or maybe some other recommendations made by doctors that may not have been taken into consideration as well.
Yeah. Okay. Thanks, Roshan.
Thank you very much.
Sorry, hey, Roshan. Would I be able to have a question real quick, Pedram? Sorry, I'm over here on
No worries,
Great presentation, Roshan. Really well put together. I was wondering, from your presentation, the extraction of the time to peak the methodology seemed to be kind of a bit of a drawback, because you said it was quite noisy. Do you think there'll be any way to sort of improve this through maybe changing image acquisition or even methodology, maybe?
Yes. So I think with the dynamic data, it could have potentially been improved by increasing the resolution of it, by perhaps taking the dynamic data every maybe 10 seconds, or I guess a higher resolution would allow for changes in TTP that were less than 30 seconds to also be detected. And then also another alternative is, in the existing literature, some papers have set a threshold TTP of perhaps if TTP is if the time activity curve spans from 0 to 40 minutes, they may set 29 minutes as a threshold between early and late TTP. So if it is present before 29 minutes, it's early. If it's after 29 minutes, it's afterwards, and so treated as a categorical variable. So I think that could have also been an interesting avenue to go down. And so yeah, I think there's perhaps those two areas off the top of my head that could certainly be improved upon.
Thank you, Roshan.
Thank you very much for the question.
Keegan, your last question.
Oh yeah, no, thank you very much, Roshan. That was, I think, an excellent presentation, especially for honours, where I know you're under a lot of time pressure. Jake actually asked most of my question to do with the chemo and how you were going to standardize that. So thanks, Jake. But also, I was wondering, you have talked about how these was quite a small study, and you had to use previous data, presumably because of the time pressure that honours students are under. Do you know roughly, like, between your multi-center options and all that sort of stuff, roughly how many patients you would be wanting to use to validate or challenge your data? Are we looking at hundreds, or 1,000 patients? Or given that you've got that method where you can subsample and all that, how many patients would you be looking at as an ideal sort of case?
Thank you very much for the question. That is certainly an interesting thing to take into consideration, just how many patients would be required. From the nature of how machine learning and how deep learning tends to work, I guess the more the better. However, and if I do compare it with the existing radiomics literature, in particular the papers that may have implemented machine learning models, they also tended to have quite small sample sizes of 20 to 30 patients. So it's a little challenging perhaps to state an exact number. However, from my understanding with the data set that was analyzed in this study, it's actually a subset of a larger encompassing study that had a few hundred patients. So if that many sets of data were available, then perhaps the results could have had more statistical power, and there could have been more in-depth analysis of things like confidence intervals and those sorts of elements. But yeah, I can't. I guess I don't know a specific number, but perhaps if all the patients who were in the previous study, who were in the encompassing study, were also included, if their data, then that may have helped.
Thank you. Thanks.
That's good. Thanks very much, and thanks to ML Cluster, because I know that Roshan was attending ML Cluster during the last year. It's good to know, everyone, that Roshan hasn't done any machine learning or AI unit, and he learned all of these things himself, which is very, I can say, rewarding and impressive. Well done, Roshan, and all the best with your studying medicine, because Roshan, after this honors, is going to do medicine. Well done.
And before I do go, I would like to say thank you very much to Martin and Nathaniel and Pejman, yourself as well as the whole machine learning cluster group and all of medical physics UWA, because it's been a wonderful environment to work under. And without all of your support, I don't think I would have been able to do this at all. So thank you all very much for that. And I hope that in the future, I either get to work with you all or for you all.
Definitely, you'll be a great doctor, Roshan, and you're more than happy to have more collaboration in the future.
Thank you very much.
Excellent.